Your surgeon can discuss likely repairs before skin cancer surgery, but the final cancer-free wound chooses the final plan.
Now, if you're scheduling surgery for a small spot on your cheek, you might be wondering, why can't we just guarantee a simple straight-line stitch today? Well, because the spot you see on the surface is really only part of the story, and the true boundary has to be mapped out first. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Section 1. The final wound decides. Predicting the unseen. To understand why a final plan requires patience, think of skin cancer kind of like an iceberg. A biopsy just identifies that visible spot on top. It proves the cancer is there, but it doesn't draw the exact underground border. Mohs surgery removes a mapped layer, examines the properly processed margins, and then traces any hidden, microscopic extensions to preserve your healthy tissue. What that means is the final cancer-free wound can actually be surprisingly wider or deeper or even closer to an important structural landmark than a simple surface photograph could ever prove.
Which brings us to part 2, 6 questions driving the plan, moving from prediction to anatomy.
So, while the exact repair has to wait for that microscopic confirmation, surgeons don't just go in blind. They build an honest plan with different branches beforehand by looking at 6 key variables. First up, size and depth. The surface diameter is just the starting point. Missing structural layers matter immensely. Second, location, because skin moves very differently on your scalp compared to, say, your cheek. Third, unmovable landmarks. Fourth, the available nearby tissue and its blood supply. Fifth is patient health, including things like circulation or bleeding risks. And sixth, your personal priorities. The rule of thumb here is memorable. Size starts the conversation, but depth, location, health, and priorities finish it.
Next section, the main repair choices. Selecting the right tool.
Now you're probably thinking, okay, but if the wound on my cheek turns out to be too complex for a simple stitch, what actual tools are on the table? Well, there is no universal winner here. The whole goal is to find the least burdensome repair that protects function, coverage, and contour. We've got linear closures that bring edges together in a planned line, local flaps that move nearby skin over, skin grafts that borrow skin from a donor site, and staged or delayed repairs. Every single option solves a specific structural problem, but as you'd expect, they each introduce a unique trade-off.
Let's clear up a really common misconception about 2 of those tools. A local flap moves nearby skin while actually keeping its original blood supply attached. This often gives you the absolute best match for color and texture. A full-thickness skin graft, on the other hand, transfers skin completely disconnected from its original blood supply, relying entirely on the new wound bed for circulation. And here's the key takeaway. A graft is not a failed flap. No, it's just a different tool, one that's perfectly suited for situations where pulling nearby skin might distort important anatomy.
Another fantastic choice is second intention healing. This basically involves just letting the wound naturally fill, contract, and grow new skin from the edges completely without stitches. I know it sounds surprising, but leaving a wound open isn't unfinished care, and it definitely doesn't mean nothing was done. In the right wound, it can be a highly deliberate reconstruction choice that successfully avoids making another incision entirely.
Okay, let's pause for a second. We know the final wound dictates the plan, and we've just seen the reconstructive tools available. But coming back to that spot on the cheek, how does a surgeon practically choose between a line, a flap, or natural healing when dealing with highly sensitive areas on the face? Well, the guiding question for every surgeon is always this: what problem will this option solve, and what new problem might it create?
That leads us right into our next section, why location changes everything, protecting form and function.
Here's a fact that might totally surprise you. Lengthening a wound into a long, low-tension line often heals significantly better than a short closure that tightly pulls on nearby features. A round wound usually just can't be closed as a short circle without bunching up the tissue. So by extending the ends, the tension spreads out nice and flat. A longer line placed safely near a natural crease, it's actually a really elegant solution.
Managing that tension is absolutely critical because we have to protect essential functional landmarks. We're talking about the eyelid margin, the nostril rim, the red-white border of the lip, and the ear rim. Imagine if your cheek were stitched too tightly. It could easily pull your lower eyelid downward, right? And that affects your ability to blink or drain tears. So, the chosen repair must actively direct tension away from these delicate borders.
And it's important to note that the rules for facial reconstruction don't automatically apply everywhere else. Take the hand, for example.
Preserving tendon glide and functional grip vastly outweighs a perfect cosmetic appearance. Or on the lower leg, where we absolutely have to prioritize circulation and account for much slower healing. The functional geography of the wound literally dictates the priority of the repair.
Moving on to our next section, timing and your surgical team, the pathway to healing.
Based on all these geographic and tension factors, you might be asking yourself, am I likely going to leave with an open wound? Or does this all usually happen in a single day? Well, looking at a large U.S. database containing over 600,000 Mohs cases, same-day repair was common for roughly 4 out of 5 procedures. But hey, if your repair is delayed, it isn't a sign that something went wrong. Not at all. Deliberate delay is a strategic choice. The surgical team might just be waiting for additional pathology, giving the wound bed time to prepare for a successful graft, or simply allowing time for swelling to subside.
And speaking of the team, fellowship-trained Mohs surgeons routinely perform reconstructions in functionally sensitive sites as a core part of their discipline. However, collaboration with another specialist is incredibly valuable if a defect happens to require complex airway work, major inner lining replacement, severe eyelid or lip function reconstruction, or general anesthesia.
Which brings us to the final stage of this decision process: setting your healing expectations. Evidence versus the individual. The good news? Mohs surgery is exceptionally safe. A prospective multi-center study of 20,821 procedures recorded an overall adverse event rate of just 0.72%. But while this population average is highly reassuring, it's important to remember that it can't serve as a personal guarantee of a flawless scar for, say, a medically fragile patient or for a highly complex flap or graft.
Because your wound and medical history are entirely unique, you absolutely must strictly follow the repair-specific wound care instructions provided by your treating team rather than some universal schedule you found online. Healing is a pathway, you know? The appearance, swelling, and redness will actually continue improving for up to a full year after surgery.
So, when your cancer is completely clear, make sure to ask your surgeon to show you the final wound and explain why their recommended repair fits your specific anatomy, health, and priorities. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. We definitely invite you to read the complete, thoroughly sourced article at Skin Trust to help guide your next conversation with your doctor. But that leaves a critical, lingering question. Once that cancer is mapped and removed, how exactly does the lab confirm it's truly gone on a microscopic level? Check out our next explainer on decoding your pathology report to find out.